Have you ever been in the ICU, especially with one of your patients? Well, you might have actually seen patients in the ICU, but you can also see them outside of that. And your patient may have had shock. And shock can be related to many different reasons, and we're going to discuss those today.
Shock. That word has impact. Shock in the medical world is a scary word. We don't want our patients to go in shock. And there's a lot of different reasons shock does occur, and we're going to discuss those today. What's going to be interesting is a lot of you guys have experienced some patients who've probably gone into septic shock, distributed shock, hypovolemic shock, anaphylactic shock. Well, whatever shock they went through, there was something that occurred first. And we need to label what is that, what kind of shock, and how is it treated. We're also going to learn about SIRS and MODS, which is multi-organ system failure, and pretty much it's going to go and discuss with you about what happens when shock does not get resolved.
So shock is a syndrome of decreased tissue perfusion, which usually leads to hypoxia, and it's the result of generalized systemic response to impaired cellular metabolism. The exchange of oxygen and nutrients at the cellular level is, of course, essential to life. So if you have hypoxia, it leads to ischemia, which then leads to death. When a cell experiences a state of hypoperfusion, the demand for oxygen and nutrients exceeds the supply at the microcirculatory level. So there's classifications of shock, and if you look at the picture on the right, it'll kind of show you what's found under these four specific classifications. Cardiogenic is kind of a compromisation of cardiac output, where hypovolemic is a loss of intravascular volume. And then we have distributive shock, which is misplaced intravascular volume, and then of course obstructive. Although the cause, initial presentation, and management vary for each type of shock, the physiologic response of the cells to hypoperfusion are similar. Mortality rates for patients with cardiogenic shock approach about 60%. Decreased filling of the heart will result in decreased stroke volume. Systolic dysfunction is the heart's inability to pump the blood forward. Primarily affects the left ventricle because systolic pressure is greater on the left side of the heart. When systolic dysfunction affects the right side of the heart, blood flow through the pulmonary circulation is reduced. And of course, these are some precipitating causes that lead to cardiogenic shock, which is things like an MI or extreme cardiomyopathy or even blunt cardiac injury, cardiac tamponade, etc. So if the heart cannot pump blood to where it's needed, then that is where cardiogenic shock occurs. In cardiogenic shock, because of low blood flow, a patient might experience tachypnea, pulmonary congestion, because the heart's not working properly, so it's backing up. Maybe pallor, cool, clammy skin, of course, decreased capillary refill time because we're getting low blood flow, which would also lead to low oxygenation. And because of that low oxygenation, anxiety, confusion, and agitation can show up. There might be an increase in capillary wedge pressure, which is PCWP, and this provides an indirect estimate of left atrial pressure, or LAP. Although left ventricular pressure can be directly measured by placing a catheter within the left ventricle, it is not feasible to advance this catheter back into the left atrium. So in terms of hypovolemic shock, there's actually two categories here. So we have absolute hypovolemia, which is really just a loss of intravascular fluid volume, and relative hypovolemia. Now the difference is that relative hypovolemia results when fluid volume moves out of the vascular space, not out of the body, but out of the vascular space into the extravascular space, which is termed intracavitary space or third spacing. So absolute hypovolemia is where you actually lose that fluid and it gets out of the body. So that could be a hemorrhage, GI loss like vomiting or diarrhea, some sort of diuresis or diabetes insipidus for uncontrolled blood sugars, etc. So find out which difference there is, because the first indicator changes, especially with the LOC again. So that's going to be kind of your sensitive change that occurs when you're getting too low and you're becoming hypovolemic. So in our case study, Alvin is a 27-year-old male who arrives through the ambulance to the ED with multiple gunshot wounds to the abdomen. He is unresponsive and his blood pressure is extremely low at 56/32. And his heart's compensating a little bit for that low blood pressure, so it's up at 148. So what type of shock is he experiencing? Well, if we look at this shock, he's losing blood loss. So that's kind of under the category of hemorrhage or absolute. So he's got hypovolemia or hypovolemic shock. And in terms of what other clinical manifestations would you anticipate, I would anticipate his heart rate to go up, as well as possibly anxiety, maybe decreased stroke volume, urinary output that decreases as well, just because of the loss of fluid intravascularly. An overall assessment of physiologic reserves may indicate the patient's ability to compensate. So, for instance, a patient may compensate for a loss up to 15% of the total blood volume, which is, if we approximate that, about 750 mils. Further loss of a volume of 15 to 30% will result in a sympathetic nervous system mediated response. This response results in an increase in heart rate, cardiac output, respiratory rate, as well as depth. Stroke volume, central venous pressure, and POP, or PAWP, are decreased because of the decreased circulating blood volume. If volume loss is greater than 30%, compensatory mechanisms may fail, and immediate replacement with blood products should be started, of course, because it's a volume issue. Loss of autoregulation in the microcirculation and irreversible tissue destruction occur with loss of more than 40% of total blood volume. Some common laboratory studies and assessments that are done include serial measurements of H&H, which of course is hemoglobin and hematocrit, electrolytes, lactate, you might have heard of that one, blood gases, as well as central venous oxygenation, which is SVO2, as well as hourly urine outputs. So we just covered this in our last section, but this is neurogenic shock, which can occur within 30 minutes of a spinal injury, usually an injury to the spinal cord at T5 or above. The injury results in a massive vasodilation without compensation due to the loss of the SNS vasoconstrictor tone. This massive vasodilation leads to a pooling of blood in the blood vessels, tissue hypoperfusion, of course, because the blood's not getting to where it needs to, and ultimately impairs cellular metabolism because it requires oxygen. Depression of the vasomotor center of the medulla from drugs, which could be maybe from opioids or benzodiazepines like Ativan, can also lead to decreased vasoconstrictor tone of the peripheral blood vessels, resulting in neurogenic shock. And this, of course, can last up to 6 weeks. So initially, the patient's skin will be warm due to the massive dilation. As the heat disperses, though, the patient is at risk for hypothermia. Later, the patient's skin may be cool or warm depending on the ambient temperature. And one thing that term is called is poikilothermia, which is taking on the temperature of the environment. And here's a picture of just kind of how to remember neurogenic shock in a more simple way. Here's a picture of neurogenic shock just to help us remember what we kind of just went over. Anaphylactic shock is a hypersensitivity reaction to a sensitizing substance. So this could be a drug. So that's why we ask about drug allergies. Maybe a chemical though, or a vaccine. What about food, like a peanut allergy, or an insect venom? So that could also include bee stings. As capillary permeability increases, fluid leaks from the vascular space into the interstitial space. So it's a distributive issue. It's not that they're losing volume because of blood loss, like a hemorrhage where it exits the body, or maybe it goes into a cavity. This is more something a little bit different because of the capillary permeability increasing, it third spaces in a sense. Anaphylactic shock can lead to respiratory distress, so bronchoconstriction, due to laryngeal edema or severe bronchospasms, and circulatory failure from the massive vasodilation. A patient can develop a severe allergic reaction, possibly leading to anaphylactic shock, after contact with inhalation, ingestion, or injection with an antigen. And remember, antigens are really allergens, or our body looks at it as bad, to which the person has previously been sensitized. So what do? Well, you don't just say, here's a steroid, or here's a H1 blocker, H2 blocker, or not an H2 blocker, but an H1 blocker. You would give them epi, because this is a medical emergency and there's not enough time for those things that take sometimes over 30 minutes to 60 minutes because this is happening rapidly. The patient experiences sudden onset of symptoms. A patient can have a severe allergic reaction, possibly leading to anaphylactic shock after, of course, contact with the antigen. Parenteral administration of the antigen or allergen is the route most likely to cause anaphylaxis. However, oral, topical, and inhalation routes can also cause anaphylactic reactions, and these are some clinical manifestations that you might see. And again, here's kind of a picture to help us remember kind of what causes as well as some manifestations that could occur with anaphylactic reaction. So another distributive shock is sepsis, which is systemic inflammatory response to a documented or suspected infection. Now, the main organism that causes sepsis are usually gram-negative and gram-positive bacteria. Maybe parasites, fungi, and viruses can also cause the development of sepsis as well as septic shock. In as many as 10 to 13 or 30% of patients with sepsis, the causative organism is not identified. When severe sepsis is diagnosed, this means sepsis plus an organ dysfunction, and this is diagnosed in more than 750,000 patients per year, with of course a mortality rate as high as 20 to 50%. Now, when we look at septic shock, this is a presence of sepsis with hypoxia despite fluid resuscitation. And this is a presence of inadequate tissue perfusing resulting in hypoxia. So there's three major pathophysiological effects that can occur with septic shock. We get something like vasodilation, maldistribution of blood flow, and also myocardial dysfunction. Now, patients may be euvolemic, but because of the acute vasodilation, relative hypovolemia and hypotension occur. In addition, blood flow in the microcirculation is decreased, causing poor oxygen delivery as well as tissue hypoxia. The ejection fraction is decreased for the first few days after the initial insult. Because of decreased ejection fraction, the ventricles dilate to maintain the stroke volume. The ejection fraction typically improves, and the ventricular dilation resolves over 7 to 10 days. Now, persistence of a high cardiac output and a low systemic vascular resistance, which is hypotension, beyond 24 hours is often associated with an increased development of hypotension, of course, and MODS. Because when you get hypotension, of course, it's not bringing blood to the circulation, meaning it's bringing blood, but it's not bringing as much blood to these organs, which can lead to MODS, which is multiple organ system death. Now, do you remember what a normal EF is? Well, it's usually greater than 55%. When microorganisms enters the blood, the normal immune inflammatory responses are started. However, in severe sepsis and septic shock, the body's response to the microorganism is exaggerated. The release of platelet activating factor results in the formation of microthrombi and obstruction of the microvascular because, of course, microthrombi is plugging the tubes. The patient will initially hyperventilate as a compensatory mechanism, which means they're trying to suck in air. But this causes them to, of course, blow off CO2, which results in respiratory alkalosis. Once the patient can no longer compensate, respiratory acidosis will develop. Respiratory failure will develop in 85% of patients with sepsis and 40% with a developed acute respiratory distress syndrome, also known as ARDS. These patients may need to be intubated and, of course, mechanically ventilated if they are intubated because they're not able to protect their airway anymore and need extra help. Also, you might see some multiple organ system damage going on, which would, of course, maybe affect the kidneys. Because the kidneys are very sensitive to having good flow going through there, and when it doesn't, maybe that's because of hypovolemia or dehydration, it can lead to AKIs. So this would lead to sometimes decrease of urine output. Also, remember that altered neurological status could also be an indicator and is a very sensitive indicator. So a change in LOC would be one of those things. GI dysfunction, GI bleeding, and paralytic ileuses can also be seen in septic shock. So this is kind of the steps on how we get to septic shock. It might start off with SIRS, which is a systemic inflammatory response system. And these you would see some changes in, for instance, vital signs as well as lab work. Then it proceeds on to sepsis, which means that there's 2 SIRS plus a confirmed or suspected infection. Now, the difference between SIRS and sepsis is that sepsis, there is a microorganism that is identified, where SIRS, they're not sure what that is yet. Severe sepsis leads to sepsis plus signs of end organ damage and hypotension, which is that low blood pressure I was talking about, plus a lactate of greater than 4. And then, of course, we get septic shock, which is a pretty severe sepsis with persistent signs of end organ damage, meaning the kidney or something, and of course, some other criteria such as hypotension and lactates going up. So obstructive shock is something that develops when physical obstruction, it's a physical thing, to blood flow occurs with decreased cardiac output. This is caused by restricted diastolic filling of the right ventricle, and other causes include abdominal compartment syndrome, in which increased abdominal pressures compress the inferior vena cava, which is a large blood vessel, thus decreasing venous return to the heart. So, of course, you're going to have decreased cardiac output as well as increased afterload because of the pressure changes here, because there's a block in the system. Pulmonary embolism and right ventricular thrombi can cause also an outflow obstruction as blood leaves the right ventricle through the pulmonary artery. And this leads to decreased blood flow to the lungs, as well as decreased blood return to the left atrium. Now, other signs or clinical signs include jugular vein distension, which is found on your neck, and pulsus paradoxus, which is a change in blood pressure during inspiration. Now, a rapid assessment and treatment are important to prevent further hemodynamic compromise and possibly cardiac output. So in our case study, Alvin's heart rate continues to increase and is now 192. That's pretty high. Of course, BP is now super low at 52/34. He has no UO, or urine output, since admission, and that's not a good sign. And bowel sounds are hypoactive, and his skin is cool and clammy. So what stage of shock do you think is Alvin experiencing? Well, right now in the stage of shock, I think he's in the compensatory mechanism stage because he's kind of trying to compensate. What compensatory mechanisms are working to maintain his cardiac output? Well, probably the vasoconstriction while blood to the vital organs is maintained. Maybe SNS stimulation will increase myocardial O2 demands. Shunting blood from the lungs increases physiological dead space. Impaired GI motility, risk for paralytic ileus. Cool, clammy skin and decreased blood to kidneys activate the renin-angiotensin system, which is going to raise his blood pressure. So shock is categorized into 4 overlapping stages, which includes the initial compensatory, which we just talked about a little bit with our case study, and progressive and refractory stages. And here's kind of just a picture to kind of go through those stages and how it affects MAP. So let's talk about the first stage of shock, which is the initial stage. Usually this is not clinically apparent, and metabolism changes are at a cellular level from the aerobic to anaerobic. Now, when we talk about aerobic versus anaerobic metabolism, aerobic metabolism means oxygen is used to help with that metabolism. But when the body can't compensate enough to give enough oxygen, it actually converts over to anaerobic metabolism, which then things like lactic acid starts to show up. And lactic acid builds up and must be removed by the liver. If you've ever ran a race and you felt sore afterwards, this could be because your body needed more oxygen than what you were getting. So you ended up getting some lactic acid, which led to some sore muscles. This is kind of the same concept, but this one instead is related to shock. Now, the process requires O2, and if unavailable due to decreased tissue perfusion, of course, turns over to anaerobic. So stage 2, in terms of shock or compensatory stage, is really the body's attempt to overcome consequences of that anaerobic metabolism, which means not getting enough oxygen and maintaining homeostasis. So the patient's clinical presentation begins to reflect the body's responses to the imbalance in oxygen supply and demand. And one of the classic signs of shock is a drop in blood pressure, which occurs because of a decrease in cardiac output and of course a narrowing of pulse pressures. Blood flow to the most essential vital organs such as the heart and the brain is maintained, while blood flow to the non-vital organs such as the kidneys, GI tract, skin, and lungs is diverted or shunted. So the myocardium responds to the SNS stimulation and the increase in oxygen demand by increasing the heart rate and contractility. Think of the SNS like kind of a fight or flight response, which means that we're going to need some energy, which is glucose, but also our blood pressure might go up as well as our heart rate. Now, however, increased contractility increases myocardial oxygen consumption because as the heart beats faster, so does the requirement of oxygen to be consumed go up as well. The coronary arteries dilate in an attempt to meet the increased oxygen demands of the myocardium, so it's trying to bring more blood flow to the heart. Physiologic dead space is the anatomic dead space, which is the amount of air that will not reach gas exchanging units, which is the lungs, and an inspired air that cannot participate in gas exchange. The clinical result of an increase in dead space ventilation is a ventilation-perfusion mismatch. Some areas of the lungs participating in ventilation that will not be perfused because of the decreased blood flow to the lungs. So ventilation-perfusion mismatch is a term used when the ventilation and the perfusion of gas exchanging unit are not matched. Arterial oxygen levels will be decreased and the patient will have a compensatory increase in the rate and depth of respirations. Remember, the body's trying to get more oxygen, so it's going to take deeper breaths. So the decrease in blood flow also to the GI tract results in impaired motility as well as slowing of peristalsis, which is the movement for the bowel movements. This increases the risk for the development of a paralytic ileus, which is kind of a paralyzation of that area in the intestines. A decreased blood flow to the skin results in the patients feeling cool and clammy. The exception is the patient in early septic shock who may feel warm and flush due to a hyperdynamic state. In this compensatory stage, there's a decrease in blood to the kidneys, which of course activates the renin-angiotensin system, or RAS. Renin stimulates angiotensinogen to produce angiotensin 1, which is then converted to angiotensin 2. Angiotensin 2 is a potent vasoconstrictor that causes both arterial and venous vasoconstriction. The net result is an increase in venous return to the heart and an increase in blood pressure. Angiotensin 2 also stimulates the adrenal cortex to release aldosterone. Remember what that does? Of course, this results in sodium and water reabsorption and potassium excretion by the kidneys. The increase in sodium reabsorption raises the serum osmolality and stimulates the release of the antidiuretic hormone from, guess where? The pituitary gland, or posterior pituitary gland. ADH increases water reabsorption by the kidneys, thus further increasing blood volume. The increase in total circulating volume results in an increase in cardiac output and blood pressure. So in stage 2, the body is able to compensate for changes in tissue perfusion. If cause of shock is corrected, the patient will recover, usually with little or no residual effects. But again, if not corrected, we'll progress into something called a progressive stage, which is stage 3. It begins when compensatory mechanisms start to fail. And of course, these patients will most likely be transferred to the ICU for advanced monitoring and treatment, because they might even also need special attention to their airway, which would be maybe ventilation. Usually changes in the patient's mental status are important findings in this stage. So the progressive stage, which is our third stage, is distinguished in terms of features of decreased cellular perfusion and altered capillary permeability. The cardiovascular system is profoundly affected in the progressive stage of shock. Cardiac output begins to fall, resulting in a decrease in blood pressure and coronary artery and cerebral as well as peripheral perfusion. In addition to the decrease in circulating volume, there's an increase in systemic interstitial edema, which means it's not going into the intravascular, it's going into like third spacing, for instance. The patient may have anasarca, which is diffuse profound edema, meaning edema everywhere on the body. Fluid leakage from the vascular space also affects the solid organs, which are the liver, the spleen, the GI tract, the lungs, and peripheral tissues by further decreasing perfusion. Of course, sustained hypoperfusion results in weak peripheral pulses as well as some ischemic episodes of distal extremities. Because remember, those distal extremities have smaller blood vessels, which then leads to, if we're really getting low blood pressure, then there's really no blood flow going to those extremities. Because the changes in the heart, you might see dysrhythmias, maybe a myocardial ischemia, possible even a heart attack, and then in the end, you'll start to see a complete deterioration of the cardiovascular system, because now we're pretty much having a heart problem, which leads to cardiogenic shock, but the pump is broken. So what happens when the pump's broken? Blood flow is not going to the rest of the body properly. So another key response in the lungs is the movement of fluids from the pulmonary vasculature into the interstitial space. As capillary permeability increases, the movement of fluid to the interstitial spaces results in interstitial edema, bronchoconstriction, and a decrease in functional residual capacity. With further increases in capillary permeability, the fluid moves to the alveoli, which is not great because that's where air should be, with resultant alveolar edema and therefore a decrease in surfactant production. To keep those alveoli open, we need to have that surfactant. So now we're getting water going into that alveoli, which is not a good thing because that is where air should be to exchange oxygen with the capillaries surrounding those alveoli. The combined effects of pulmonary vasoconstriction and bronchoconstriction are impaired gas exchange, of course, and decreased compliance, and of course, worsening ventilation perfusion mismatch. Clinically, the patient has tachypnea, crackles, and you would, of course, hear those crackles because they're in the wrong, water's in the wrong spot, and an overall increased work of breathing because they now are breathing. Of course, there's fluid in there making sounds, but they're getting less oxygen exchange because of the progression of symptoms. So, as we've talked about in the renal section, hypoperfusion or hypovolemia leads to renal tubular ischemia or atubular necrosis. The effects on the kidneys of prolonged hyperperfusion is this. The resulting acute tubular necrosis may lead to, of course, AKI. This can be worsened by things like nephrotoxic drugs, so this would be maybe certain antibiotics or diuretics or anesthetics. Patient will have a decreased urine output and an elevated blood urea nitrogen or BUN. They will also have an elevated serum creatinine because things are not being filtered the same way anymore. Things are slowing down. Of course, what else does our kidneys do? Well, it helps with sodium bicarb. So if that's not being reabsorbed or processed correctly, then metabolic acidosis occurs from the kidney's inability to excrete acids, especially lactic acid, and reabsorb bicarbonate. And remember, our kidneys actually kind of dissociate from pretty much think of the kidneys like a buffer, and it soaks up those acids but then converts it to H2O and CO2. That CO2 is usually excreted out of the lungs. So the GI system is also affected by prolonged decreased tissue perfusion. The loss of the functional ability of the liver leads to failure of the liver to metabolize drugs and waste products. So that would be maybe lactate or ammonia. As you know, with someone who has hepatic encephalopathy, they have kind of sometimes too much ammonia in their body. So there's kind of a liver failure going on to metabolize these drugs and waste products, which then causes a buildup of them. Of course, jaundice results from an accumulation of bilirubin. Remember, bilirubin is sent from the spleen as unconjugated and then conjugated through the liver, which of course sent through the gallbladder down to the biliary tract and so on. As the liver cells die, enzymes become an issue, and the liver also loses its ability to function as an immune organ. Bacteria that may move from the GI tract are no longer destroyed by the Kupffer cells. Instead, they are released into the bloodstream. So, this increases the possibility of bacteremia. Dysfunction of the hematologic system adds to the complexity of the clinical picture. The patient is at risk for DIC, in which consumption of the platelets and clotting factors results in bleeding from many orifices. And this also has something to do as well with the liver having an issue because that also helps with clotting factors. All right, in the final stage of shock, which is the refractory stage, a decreased perfusion from peripheral vasoconstriction, as well as decreased cardiac output, exacerbate anaerobic metabolism. Increased capillary permeability allows fluid and plasma proteins to leave the vascular space and move to the interstitial space, when normally they don't do that. Plasma proteins stay in the intravascular, but now that's more permeability, there's more permeability, it's now leaving the intravascular, heading to the interstitial space, which also brings fluid to that space. Blood pools in the capillary bed secondary to the constricted venules as well as dilated arterioles. Loss of intravascular volume worsens because of hypotension and tachycardia and decreases coronary blood flow. So decreased coronary blood flow leads to worsening myocardial depression, and so that leads to further decline in cardiac output. Failure of the liver, the lungs, and the kidneys will result in an accumulation of waste products such as lactate, urea, ammonia, and even carbon dioxide. The failure of one organ system affects several other organ systems. So at this point, recovery is very unlikely in this stage, and the organs are in failure, and the body's compensatory mechanisms are overwhelmed. And just to simplify the early versus late stages for shock, this is just a nice picture and also related words. So early signs would be normal for blood pressure, but late signs would be where that blood pressure starts to go down to 90 millimeters per mercury systolically, which obviously normally 120 would be a norm. So we need to get a history of what's happening here, meaning what happened before they came. So that's medical as well as even surgical history and our recent events. And recent events could mean that they just had a surgery or chest pain or trauma. And this provides valuable data for kind of why they think this is happening. Um, so there's no single study to really determine shock, but there are some things that can help us determine if someone is in that phase or someone is at risk of. So blood studies might be done, blood studies such as elevation of lactate or base deficit. If you look at table 66.2, this kind of summarizes laboratory findings seen in shock. Additional diagnostic studies include a 12-lead EKG. Obviously, my heart or this heart could have an issue, so an EKG will be good. And this, of course, if we're determining too, if it's cardiogenic shock, for instance, because of an MI. Continuous ECG monitoring is done, and these patients might be seen in the ICU, and you've seen those monitors. They're usually located in the room. And then, of course, a chest x-ray, because we know that the lungs can start flooding, especially with acute respiratory distress syndrome, etc., as well as like a PE. And then, of course, continuous pulse ox, because that could be unstable, and invasive and non-invasive hemodynamic monitoring to closely monitor any minute changes. So Alvin receives 3 units type O PRBC or packed red blood cells for profuse blood loss. Remember, he had a traumatic event. An ECG and a chest x-ray are done as well. And he will be taken to the OR for removal of the bullets and repair of injuries. So in terms of other interventions that are necessary at this stage to prevent progressive shock, I would really say monitor the airway, maybe also the O2, of course. Maybe he might need some vasopressors because he's lost a lot of blood. But if that's the case, we also need to include that he also has enough fluid in there, so the vasopressors don't cause problems for his capillaries, which might make them too small to even get oxygen to those sites. He might need a nutrition plan, etc. So some management strategies that are essential here are to identify the patient at risk for developing shock. Of course, integration of patient's history. Of course, physical exam and clinical findings to establish a diagnosis. Why is this happening? And also, what are we going to do about it? So interventions to control or eliminate cause of this decreased perfusion. That would be maybe giving vasopressors, fluids, albumin, whatever it may be, or even antibiotics. Protection organs from dysfunction. Okay, so that would be probably because we're doing the interventions, we're going to protect the organs from further declining. Provision of multi-system supportive care, as well as ensure patient is responsive, and also ensure a patent airway, because ABCs, what are they going to die from first? Airway. And we're going to maximize oxygen delivery, and sometimes supplemental oxygen and mechanical ventilation may be necessary to maintain an arterial oxygen saturation of greater than 90%, or a PaO2 greater than 60 millimeters per mercury, which is the perfusion of oxygen into the tissue to avoid hypoxemia. So we just talked about how we can supplement oxygen for our patient, but we also need to make sure that they're ventilated as well. So that could be through a ventilator. Now, how would we increase the supply of oxygen? Well, certainly we would optimize a cardiac output with fluid replacement or drugs, which means if they're hypovolemic, we would be able to give them fluids to kind of keep that vasculature intact so we don't get a cardiac collapse or hypotension. We could also increase hemoglobin by maybe a transfusion, and that might be a packed red blood cell transfusion. We could increase arterial oxygen with supplemental oxygen as well as, again, mechanical ventilation. Remember to always plan your care to avoid disrupting the balance of oxygen supply and demand. So this means space activities that increase oxygen consumption, which would be if someone is ventilated, endotracheal suctioning, or even just position changes. So we need to kind of cluster activities to kind of minimize too much oxygen consumption activities, and so we can appropriately conserve that oxygen for the patient. So, just a therapy that's cornerstone here for septic shock as well as hypovolemic and anaphylactic shock is really volume expansion, because those shocks actually cause a hypoperfusion due to hypovolemia, or pretty much your volume starts to decrease intravascularly. And before beginning fluid resuscitation, the nurse should insert 2 large bore IVs, which, what kind of gauge needle would you use? So typically it would be about a 14 or even a 16. These are IV catheters. And even sometimes if those aren't possible, an intraosseous access device as well, or a central venous catheter, so a central line or a PICC line. Both crystalloids, such as normal saline or lactated ringer, which are usually isotonic, so that's normal for our serum osmolality, it's pretty similar, and colloids, which is albumin, which is a blood product, have a role in fluid resuscitation. So in terms of volume expansion, we would look at fluid responsiveness, and this is all determined by clinical assessments that we have. So if we give them a fluid expansion volume, like such a lactated ringer, what are the vital signs doing? Is the blood pressure going up? Is the oxygen staying up? Also, maybe we'd look at cerebral and abdominal pressures. We could look at capillary refill. Are they getting that flow to the pretty much the extremities where the smallest blood vessels are, which is the capillaries? What's the skin temperature? If they're getting good blood flow, skin temperature should be pretty normal, or unless they have a fever, of course. And then looking at urine output. Urine output is a great indicator. And usually if we want to do strict eyes and O's, we might use an indwelling bladder catheter to monitor that urine output during resuscitation. When large amounts of fluids are required, you must protect the patient against 2 major complications, which is hypothermia and coagulopathy. If the patient has persistent hypotension after adequate fluid resuscitation, a vasopressor such as Levophed or norepinephrine, dopamine, which is an inotropin, and or an inotrope, which is things like Debutrex or dobutamine, may be added. The goal for fluid resuscitation is restoration of tissue perfusion. And you always have to have enough volume, meaning fluids, before you add a pressor. Because otherwise, again, those smaller vessels, which is the capillaries, can become ischemic because there's no fluid to keep them open to help with that vasoconstriction. So it vasoconstricts all the way till there's no blood flow coming to it. Now, warm crystalloid and colloid solutions, and remember colloids, albumin, for instance, or PRBCs, can be used during massive fluid resuscitation. When administering large volumes of packed red blood cells, remember that they do not contain clotting factors. Replace these factors based on the clinical situation and laboratory studies. Drugs used to improve perfusion in shock are given intravenously or IV through an infusion pump as well as a central venous line, usually not peripherals at all. These drugs have the potential to cause severe peripheral vasoconstriction, and an increase, of course, in SVR, which is systemic vascular resistance. It's what the heart has to pump against when it pumps out of the heart into the rest of the body. So this further risks tissue perfusion. The increased SVR increases the workload of the heart. And of course, this can harm a patient in cardiogenic shock by causing further myocardial damage. Although generalized sympathetic vasoconstriction is a useful compensatory mechanism for maintaining systemic pressure, excessive constriction can reduce tissue blood flow and increase the workload of the heart. So you can see this is a very fine balance and based off where the patient is at that current moment. You also want to monitor hemodynamic parameters. So you might have heard of CVP or CO, which is cardiac output, or SCVO2 or SVO2 or PA pressures, etc., or stroke volume, along with physical assessments so that fluids can be increased or vasodilator therapy can be decreased if a serious fall in cardiac output or blood pressure occurs. The vasodilation agent must often be used for the patient in cardiogenic shock, such as nitroglycerin. Vasodilation may be enhanced with nitroprusside or nipride, or nitroglycerin in non-cardiogenic shock. Protein-calorie malnutrition is one of the main manifestations of hypermetabolism in shock. Enteral nutrition should be started within the first 24 hours. However, full calorie replacement is not recommended for previously well-nourished adults early on in critical illness. Generally, though, parenteral nutrition is used only if enteral feedings are contraindicated. So start the patient on trophic feedings. This is defined as a slow drip of small amounts of enteral nutrition at maybe 10 mils an hour. Early enteral feedings enhances the perfusion of the GI tract and help maintain the integrity of that gut mucosa so we don't get things like bacteremia. Advanced feedings as tolerated and per order. So if the patient's doing well, maybe they increase that rate, not from 10, but maybe to 15 or 20 or 25, etc. If the patient has significant weight loss, rule out dehydration before adding more calories. And we would look at, for instance, their urinary output or skin integrity, etc. Large weight gains are also common because of third spacing of fluids. So, of course, with your physical assessment, see if there's any anasarca or just fluid edema somewhere in the extremities. Therefore, daily weights serve as a better indicator of fluid status than caloric needs. So in our cardiogenic shock patients, the overall goal is to restore that blood flow to the myocardium for whatever is obstructing it by restoring balance between O2 supply and demand. This means maybe a cardiac catheterization that's performed as soon as possible after the initial insult. Specific measures to restore blood flow include angioplasty with stenting, emergency revascularization, and valve replacement. Whatever the problem may be, that's some of the options that could occur for treatment. Until these interventions are performed, the heart must be supported to optimize stroke volume and cardiac output to achieve optimal perfusion. So drugs can be used to decrease the workload of the heart by dilating coronary arteries, which are the nitrates, maybe reducing preload, which is the diuretics, reducing afterload, which is the vasodilators, and reducing heart rate and contractility. So can anyone name a drug that would decrease heart rate and contractility? So a beta adrenergic blocker would be one of those. So that would be maybe our metoprolol, for example. The patient may also benefit from a circulatory assistive device. So this is an intra-aortic balloon pump or a ventricular assist device called a VAD. The goals of this intervention are to decrease the systemic vascular resistance, or SVR, and the left ventricular workload so the heart can heal. A VAD may be used as a temporary measure for the patient in cardiogenic shock who is waiting for a heart transplant. So in hypovolemic shock, management focuses on stopping the loss of fluid, of course, and restoring that circulatory volume, just like in our patient who had those gunshot wounds. Fluid resuscitation is calculated using a 3-to-1 rule. 3 mL of isotonic crystalloid, which an isotonic solution could be normal saline or lactated ringer because it's similar to our own serum osmolality, for every 1 mL of estimated blood loss. In table 66.7, this delineates the different types of fluid used for volume resuscitations, as well as the mechanism of action and specific nursing implications for each fluid type. So Alvin's surgery is successful in removing the bullets and repairing blood vessels. His EBL was at least 3 liters, or estimated blood loss, so before surgery, and 1 liter more during surgery, so that's 4 liters total. What fluids would be administered at this point to further stabilize his volume? Well, we just suggested maybe isotonic crystalloids, which would be maybe lactated ringer or normal saline, and maybe even a colloid, which is albumin. He is intubated and has a central line catheter and an arterial line. His BP is 102/54, heart rate 104, and central venous pressure is 7. So in terms of medications that could be added, he could have a vasopressor if his blood pressure is still low, and also consider broad-spectrum antibiotics since bullets are not a sterile thing and went inside his body cavity, which could maybe put him at an exposure of a bacterial infection, which of course bacterial infections can lead to septic episodes, so we want to get some antibiotics on board. So patients in septic shock do require large amounts of fluid replacement. Volume resuscitation of 30 to 50 mL a kilogram is usually done with isotonic crystalloids to achieve adequate fluid resuscitation. Albumin 4 to 5% may be added when patients require substantial volumes. A fluid challenge technique to achieve a minimum of 30 mL per kilogram of crystalloids is used and repeated until hemodynamic improvement, which means an increase in MAP and or CVP, changes in the SVV is noted. If the patient remains hypotensive after initial volume resuscitation with minimally 30 mL a kilogram, vasopressors may be added. The first drug of choice is norepinephrine. Vasodilation and low cardiac output or vasodilation alone can cause low BP in spite of adequate fluid resuscitation. So vasopressin or pitressin may be added for patients refractory to initial vasopressor therapy. Exogenous vasopressin is usually to replace the stores of physiologic vasopressin that are often depleted in septic shock. So in septic shock, antibiotics should be started within the first hour of severe sepsis or septic shock. Because if we obtain cultures, this might take 48 to 72 hours to come back. So they're going to start on something more prophylactically. And this would be broad spectrum antibiotics are given first until those specific antibiotics can be given depending on what the cultures reveal. And the cultures will reveal sensitivity to, well, first off, identify the microorganism that's causing all this, but also what antibiotic will be effective against that microorganism. Every hour delay to start antibiotics has shown to significantly decrease survival. Intensive glucose control of 81 to 108 actually increases mortality. Frequent monitoring of glucose levels of all patients in septic shock is necessary. Now, we don't want glucose levels to get too high. We do want those less than 180. And remember, Shock is kind of a fight or flight response. So our body's trying to use extra glucose to help with the energy used to help fight this infection, whatever it may be. The body is also under a bit of stress. So of course stomach acid can build up as well, which can lead to stress ulcers. So a lot of times you might see in terms of stress ulcer prophylaxis, a PPI such as Protonix or even Pepcid. DVT prophylaxis should be used as well because of sometimes DIC or just because the patient's laying in bed and is more prone to, of course, a clot. And so heparin or Lovenox can be used for that. The specific treatment of neurogenic shock is based on the cause. If the cause is spinal cord injury, general measures to promote spinal stability, such as spinal precautions, or maybe cervical stabilization with a collar, are initially used. And you would want to monitor as well as intervene for any of the symptoms related to neurogenic shock. The first strategy in managing anaphylactic shock is managing patients at risk for anaphylactic shock and its prevention. So a thorough history is key to avoiding the risk factors for anaphylaxis. Now, IM epinephrine is the first drug of choice to treat anaphylactic shock. It causes peripheral vasoconstriction as well as bronchodilation and opposes the effects of histamine. So epinephrine actually affects alpha 1, which actually increases vasoconstriction, beta 1 stimulates beta 1, and beta 1, of course, increases heart rate and contractility or cardiac output, and then also beta 2, which actually causes bronchodilation. Now, aerolized epinephrine can be used to treat laryngeal edema. Benadryl or diphenhydramine, along with ranitidine or Zantac, are given as adjunct therapies to block the ongoing release of histamine from the allergic reaction, trying to stop this cascade of events. Hypotension results from leakage of fluid out of the intravascular space into that interstitial space as a result of increased vascular permeability as well as vasodilation. Mechanical decompression for pericardial tamponade, tension pneumothorax, and a hemopneumothorax may be done by needle or tube insertion. Obstructive shock from a pulmonary embolism may require thrombolytic therapy. Superior vena cava syndrome is a compression or obstruction of the outflow tract of the mediastinum and may be treated by radiation, debulking, or removing the mass or cause. A decompressive laparotomy may be indicated for abdominal compartment syndrome for patients with high intra-abdominal pressure and hemodynamic instability. As a nursing assessment, we are always concerned about the ABCs. Really, what is the patient going to die from first? Usually, if the airway is not intact, then that will be the first cause. But of course, all three of these are mightily important because they can die of these all rather quickly if things go dramatically wrong. So again, we would look at nursing assessments related to shock, and we would focus our assessments on things like tissue perfusion, which you could evaluate that through things like vital signs, urine output, maybe the skin, capillary refill, etc. We would also look at the brief history of what's actually causing this shock. Can we get rid of the agent that's causing this to happen? And also, how long has this been happening? And then also just be aware of the health history, which is what medications were they taking, what's new, what's not. Of course, making sure that you're not doubling up on any medications that are being ordered for them. And then what allergies do they have so you don't cause an anaphylactic shock, something to add to that, as well as maybe any vaccinations or recent travel. So Alvin's airway and breathing are successfully managed through mechanical ventilation. His incisions are clean, dry, and intact. His blood pressure is now 118/62 and heart rate is 92, so these are looking a little bit better. Alvin's mother and girlfriend arrive in the ICU. His mother tells you that he has a history of GERD but is otherwise healthy. So what is our goals? We have a lot of goals for our shock patients, but one is the evidence of adequate tissue perfusion, and this would be the restoration of their normal or baseline BP. Of course, a large bore diameter peripheral IV and fluids so that we can establish that reperfusion. And then we would want to see some recovery of organ function, including things like kidneys, heart, and lungs. We also want to avoid with any interventions or just them being in the hospital, complications from them being here. So that's maybe if they had a catheter placed for strict eyes and nose, maybe we'll prevent CAUTI, which is catheter-associated UTI, or if they've been ventilated, maybe VAP or ventilator-associated pneumonia. And we'd also include prevention of healthcare-acquired complications of disease management and care, and also avoidance of complications from prolonged states of hyperperfusion. So any person who has surgery or trauma is at risk for shock resulting from hemorrhage, spinal cord injury, sepsis, or other conditions. For example, a person with an acute anterior wall MI is at high risk for cardiogenic shock. The primary goal for this patient is to limit the infarct size. This is done by restoring coronary blood flow through percutaneous coronary intervention, which is done in the cardiac cath lab, thromboembolic therapy, or surgical revascularization. Rest, analgesics, and sedation can also reduce the myocardial demand for the heart. Other people at risk would be maybe older patients or immunocompromised patients or someone with a chronic illness. So a lot of times someone with a history of diabetes might take a little bit longer to heal, and so there could be more higher risk for infection as well as delayed healing. So we want to prevent shock as well. And in terms of planning, we would monitor fluid balance to prevent hypovolemic shock, and of course practice good hand hygiene, which is just a standard precaution in general, but this also helps prevent the spread of infection, for instance. So Alvin stabilizes over the next 2 days and is extubated. He recognizes his family. He has many questions regarding why he is here. So what kind of things would you discuss with a patient in terms of supportive care for Alvin? Maybe what consults would be helpful? So in terms of neurological status, if someone is in kind of a severe state of shock and they're in the ICU, just like how Alvin was, he's got a big chance of getting something called ICU delirium, which is kind of just being disorientated with time and even place, especially with the sedatives as well as ventilation and just the trauma of it all. So we want to assess the patient's neurologic status every 1 to 2 hours. Of course, we're doing this all the time, but when we're in the room, we're making sure we're making a point to check that every hour, really. The patient's neurological status is the best indicator of cerebral blood flow. As you know, that a state of level of consciousness can decrease with changes in cerebral blood flow as well as ICP pressures when there was traumatic events. So signs of that you would want to be aware of the changes in behavior, so irritability, restlessness, hyper alertness maybe, or blurred vision, or even confusion or paresthesias. We want to assess the patient's neurological status, including orientation, of course, level of consciousness. Patient's neurologic status is the best indicator of cerebral blood flow, so be aware of the clinical manifestations that may indicate neurological involvement. If the patient is unstable, continuously assess heart rate and rhythm, blood pressure, central venous pressure, and PA pressures, including cardiac output, maybe systemic vascular resistance, and stroke volume if available. We want to monitor trends in hemodynamic parameters, which yields more important information than just single numbers. So, in terms of neurological status, if someone is actually in ICU because of some sort of shock, they're probably at risk of something called ICU delirium, ICU delirium is kind of causal because first off, they've got a lot of sedatives, maybe they've had a traumatic event, and so they're starting to get confused with kind of what's going on and why they're here. So that would be like our case study, for instance. So assess the patient pretty frequently. So this is assess patient's neurological status every 1 to 2 hours, but even more than that if you see any changes. The patient's neurologic status is the best indicator of cerebral blood flow, which is huge because if we're in shock, we might be getting hypoperfusion. So be aware of changes in behavior, restlessness, maybe hyperalertness, blurred vision, confusion, and even paresthesias. We also want to orientate them to person, place, time, and events, just to tell them what is happening, and that would be a good idea for a case study. We would reduce noise and light levels in the ICU just to prevent too much stimulation, and would keep a day-night cycle so that they kind of have more of a rhythm to their day and they don't start getting confused about what time of day, etc., but just orientating them to that. If the patient is unstable, continuously assessing heart rate and rhythm, blood pressure, CVP, and PA pressures, including cardiac output and SVR or systemic vascular resistance, and stroke volume if available. Monitoring trends in a hemodynamic parameters yields more important information than just these single numbers. Patients in shock often have hypotension, so the Trendelenburg or head down position should not be used to treat hypotension. This is only emergent sometimes, but usually it's not treated for hypotension. So patients in this position may experience compromised pulmonary function as well as increased intracranial pressure. Continuously monitor the patient's ECG to detect dysrhythmias that may result from cardiovascular and metabolic abnormalities, such as electrolyte imbalance, associated with shock. Assess heart sounds for the S3 or S4 sound, or even new murmurs, which is telling us about their valves in their heart having some dysfunction. An S3 sound usually indicates heart failure. Initially, you want to monitor the rate, depth, and rhythm of respirations every 15 to 30 minutes. Increased rate and depth provide information regarding the patient's attempt to correct metabolic acidosis. Remember, if it increases, it could actually start the body's trying to blow off that CO2. Pulse oximetry using a patient's finger may not be accurate in a shock state because of poor peripheral circulation. Instead, attach the probe to the ear, nose, or forehead according to the manufacturer guidelines to increase accuracy. Arterial blood gases, or ABGs, provide definitive information on ventilation and oxygenation status and acid-base balance. A PaO2 below 60 millimeters per mercury in the absence of chronic lung disease indicates hypoxemia. And what's PaO2? PaO2? That's perfusion into the tissue of oxygen. So, if this person has signs and symptoms of hypoxemia, they may need higher oxygen concentrations or maybe have a different mode of oxygen administration. Maybe they're not receiving it the best, maybe through the nasal cannula, and so they need it by the mouth. Low PaCO2 with low pH and low bicarbonate level may indicate that the patient is attempting to compensate for metabolic acidosis from increasing lactate levels. A rising PaCO2 with persistently low pH and PaO2 indicates the need for advanced pulmonary management. Many patients in shock are intubated and on mechanical ventilation. Maintaining a patent airway and monitoring for ventilator-related complications are critical, such as VAP. Urine output of less than 0.5 milliliters per kilogram per hour may indicate inadequate perfusion of the kidneys. Also use trends in serum creatinine values to assess renal function. So of course, if you see those climbing every day, that's not good. Monitor temperature every 4 hours if normal. In the presence of an elevated or subnormal temperature, obtain hourly core temperatures. And core temperatures would be found urinary, central line, or PA catheters. Monitor the patient's skin, upper and lower extremities for signs of adequate perfusion. Changes in temperature, pallor, flushing, cyanosis and diaphoresis, as well as piloerection or goosebumps, may indicate hypoperfusion. Auscultate bowel sounds at least every 4 hours and monitor for abdominal distension. If an NG tube is present, measure drainage and check for occult blood. Remember, check for kind of ulcers, for instance. Similarly, check all stools for occult blood, which would also indicate an ulcer as well. And ulcers can occur with someone in shock because their body's under stress. Hygiene is especially important for the patient in shock because impaired tissue perfusion predisposes the patient to skin breakdown and infection. So certainly perform bathing and other nursing measures carefully because a patient in shock is experiencing problems with oxygen delivery to tissues. So we don't want to overdo the oxygen consumption with these specific care plans. Now, monitor trends in oxygen consumption by maybe things like SpO2 during all nursing interventions to assess the patient's tolerance for these activities. So, fear and anxiety and pain may aggravate these respiratory symptoms. So, sometimes we might need to give them drugs PRN. Now, I would be careful about some drugs because some of these drugs can cause respiratory depression, such as morphine and Ativan. Provide drugs to decrease anxiety and make sure that they're appropriate. Now, there's also opioids or sedatives, such as propofol, and these are extremely helpful in decreasing anxiety and pain, especially if someone is ventilated. Talk to the patient and encourage the caregiver to talk to the patient as well, even if the patient is intubated, or sedated, or appears comatose. Hearing is often the last sense to decrease. Give the patient simple explanations of all procedures before you carry them out, as well as information regarding the current care plan. Do not overlook the patient's spiritual needs. Patients may desire a visit from a chaplain, priest, rabbi, or even minister. Also, in terms of privacy, we should also keep that there, and usually we do. I mean, unless someone needs to be in a single room, but in the ICU, you'll be in your room by yourself. And make sure that the patient will also have things like call lights within reach if they can call us. And I say if they can call us. If they're heavily sedated, we need to be in there checking on them frequently. So continue to monitor the patient for indications of complications throughout the recovery period. These may include a decreased range of motion, maybe muscle weakness, because there's some deconditioning if you're in the bed for prolonged periods of time. Maybe they're going to have decreased physical endurance, or even acute kidney injury or acute tubular necrosis, and fibrotic lung disease from ARDS. Patients recovering from shock often require diverse services after discharge. These can include admissions to transitional care units, especially for mechanical ventilation weaning, rehabilitation centers, inpatient versus outpatient, or home health agencies. So start planning for a safe transition from hospital to home as soon as the patient is admitted to the hospital. So let's test ourselves. When assessing a patient in shock, the nurse recognizes that the hemodynamics of shock include A. Normal cardiac output in cardiogenic shock, B. Increase in central venous pressure in hypovolemic shock, C. Increase in systemic vascular resistance in all types of shock, or D. Variations in cardiac output and decreased system vascular resistance in septic shock. Well, if you guessed D, you guessed right. Septic shock has 3 major pathophysiological effects, one including vasodilation, maldistribution of blood flow, and myocardial depression. Patients may be normal volemic, but because of acute vasodilation, relative hypovolemia and hypotension may occur. The ejection fraction is decreased for the first few days after the initial insult. Because of decreased ejection fraction, the ventricles will dilate to maintain stroke volume. The ejection fraction typically improves and ventricular dilation resolves over 7 to 10 days. Persistence of high cardiac output and low SVR beyond 24 hours is an ominous finding and is often associated with increased development, of course, of hypotension and MODS. Systemic vascular resistance, or SVR, increases in cardiogenic and hypovolemic shock. SVR decreases in neurogenic, anaphylactic, and septic shock. Cardiac output decreases in cardiogenic shock, and central venous pressure decreases in hypovolemic shock. The nurse is caring for a critically ill patient. The nurse suspects the patient has progressed beyond the compensatory stage of shock. If what occurs? A. An increase in blood glucose levels. B. An increase in serum sodium levels. C. An increased serum calcium levels. Or D. Increased serum potassium levels. Well, the answer is D. And hyperkalemia occurs in the progressive phase of shock when cellular death liberates intracellular potassium. Hyperkalemia will also occur in an AKI and in the presence of acidosis. The nurse is caring for a patient in septic shock. Which hemodynamic change would the nurse expect? A. Increased ejection fraction. B. Increased mean arterial pressure. C. Decreased central venous pressure. Or D. Decreased systemic vascular resistance. Well, remember this patient's in septic shock. So there would be probably a change in systemic vascular resistance, which makes D correct. Patients in septic shock will have a decreased systemic vascular resistance, decreased ejection fraction, not increased, and decreased mean arterial pressure because they're becoming hypotensive. Decreased central venous pressure, or preload, is expected in hypovolemic or obstructive shock. So now we're going to go into more detail about SIRS and MODS. So SIRS have been mentioned before, but it's a systemic inflammatory response to a variety of insults. It means inflammation in organs, but not near the initial insult. So insults resulting in SIRS include infection, referred to as sepsis, ischemia, infarction, and injury. So SIRS triggers can include mechanical tissue trauma. So this would be, for instance, burns, crush injuries from an accident, or even surgical procedures. Then also abscess formation, such as intra-abdominal extremities, and then ischemic necrotic tissue, such as pancreatitis, which is when the pancreas is kind of eating itself and cause of autodigestion because of inflammation. The amylase lipase doesn't get activated in the duodenum, it gets activated in the pancreas. Or other ischemic necrotic tissues such as vascular disease or MI. Other triggers would be microbial invasions, so this would include things like bacteria, viruses, and fungi, or endotoxin that's released with gram-negative bacteria. Also, global perfusion deficits, which would be like maybe a post-cardiac resuscitation or shock states, so all the shock states. And then regional perfusion deficits, so this would be a distal perfusion deficit specifically. So what is MODS? Well, MODS is a failure of two or more organ systems, and this is when homeostasis cannot be maintained without interventions from the results of SIRS. Now, these two syndromes represent the ends of a continuum. Transition from SIRS to MODS does not occur in a clear-cut manner, just to let you know. Now, primary MODS versus secondary MODS is primary MODS is well defined. It's direct insults that causes MODS. So normally organ dysfunction occurs early in this one, where secondary MODS, it's a consequence of widespread sustained systemic inflammation, and dysfunction involves organs not involved in the initial insult. So this picture here is kind of relating all three together, shock, SIRS, and MODS, and how it all kind of comes together. So shock, you have a number of different ways we can have shock, which leads to things like SIRS, and then SIRS then starts to progress to MODS, which targets these specific organs, and pretty much that's every organ in the body. So Kate is a 29-year-old who was brought to the ED by her mother with confusion, fever, and flu for past week. She has been vomiting for the past 2 days and has been noting some generalized edema. Vital signs are temperature is 103.7, heart rate's 114, respirations is 26, and BP is dropped to 86/56. So what is she at risk for based on her vital signs? Well, I would say she's at major risk for decreased perfusion or hypoperfusion. She's also kind of at a hypermetabolic state with demands from her temperatures going up and her heart rate's going up, requiring more oxygen. So her body's compensating with her respirations going up as well, which could lead to maybe even a respiratory alkalosis because she's bowling off too much CO2. But you can see that her blood pressure is dropping, so this is where that decreased hypoperfusion occurs. She could also be at risk of coagulation or microembolize. Why do you think she has edema? Well, I think it's because her body is going into shock, which is leading to increased vascular permeability. So increase in vascular permeability allows mediators and protein to leak out of the endothelium and into the interstitial space. White blood cells begin to digest the foreign debris and the coagulation cascade is activated. Hypotension, decreased perfusion, microemboli, and redistributed or shunted blood flow eventually compromise organ dysfunction, of course. The baroreceptor reflex causes release of inotropic, or increasing force of contraction, and chronotropic, which is increasing heart rate, factors that enhance cardiac output. To compensate for hypotension, cardiac output increases with an increase in heart rate and stroke volume. Increases in capillary permeability causes a shift of albumin and fluid out of the vascular space where it should be, further reducing venous return and thus preload. Other signs include decreased capillary refill, skin mottling, increased CVP and POP, and also dysrhythmias. Remember, POP is pulmonary artery wedge pressure. The respiratory system is often the first system to show signs of dysfunction in SIRS and MODS. Inflammatory mediators have a direct effect on the pulmonary vasculature. The endothelial damage from the release of inflammatory mediators causes an increased capillary permeability. This causes movement of fluid from the pulmonary vasculature into the pulmonary interstitial space to the alveoli, which is not good because it's caused alveolar edema, which now doesn't allow a lot of oxygen to be exchanged with the capillary. Type 2 pneumocytes are damaged and surfactant production is decreased, which causes these alveoli to collapse. Alveolar collapse creates an increase in shunt, or blood flow to the lungs, that does not participate in gas exchange, and worsens ventilation perfusion mismatch. The end result is ARDS, which is acute respiratory distress syndrome. And there's 4 stages in that, and the last stage is pretty much refractory, meaning poor prognosis. Patients with ARDS require aggressive pulmonary management with, of course, mechanical ventilation, and the patient may become confused and agitated, combative, disoriented, lethargic, or even comatose. Now, in terms of the neurologic system, the mental status changes due to hypoxemia can occur along with inflammatory mediators or impaired perfusion, often early signs of MODS. Decreased perfusion to the kidneys activates the SNS and the renin-angiotensin system. The stimulation of the renin-angiotensin system, or RAS, results in systemic vasoconstriction. That's kind of the result of RAS. And also aldosterone-mediated sodium and water absorption to help with that fluid going into the intravascular space. So careful monitoring of drug levels is essential to avoid nephrotoxic effects, because if the kidneys are declining, that means because the kidneys are the main excretors, with drugs, then they could also become more at risk of nephrotoxic effects if the kidney function is declining. In the early stages of SIRS and MODS, blood is shunted away from the GI mucosa, making it highly vulnerable to ischemic injury. Decreased perfusion to the kidneys is a big issue, especially for any medications that you might take. Which antibiotics, that's why we do sometimes a peak and trough, like when we do vancomycin or tobramycin, etc. And of course, we talked about GI system as well being affected, which means motility decreased perfusion, and what that can indicate and what that could entail, as well as potential for bacterial translocation going into the blood, which leads to bacteremia. So usually in SIRS and MOD, someone is in a hypermetabolic state, and this is indicated by things like hyperglycemia or even sometimes hypoglycemia. Hyperglycemia can occur with glycogen stores that are rapidly converted to glucose. Once glycogen is depleted, amino acids are converted to glucose, called glucogenesis, reducing protein stores. Fatty acids are mobilized for fuel. Catecholamines and glucocorticoids are released, resulting in, of course, hyperglycemia and insulin resistance. Kind of that fight or flight response, right? We need energy to get away from the bear. So the net result is a catabolic state, and lean body mass muscle is lost. The liver cannot make albumin, one of the key proteins that has an essential role in maintaining plasma oncotic pressure, which means keeping pretty much the intravascular volume where it should be. Consequently, plasma oncotic pressure is altered and fluid and protein leak from the vascular space to the interstitial space, which of course is third spacing. Administration of albumin does not normalize oncotic pressure in these patients at this point when they have kind of a permeability that's going on. All it's going to do is pretty much send it back into the interstitial space, which is not where it needs to be. As the state of hypermetabolism persists, the patient cannot convert lactate to glucose, and lactate accumulates, forming lactic acidosis. DIC causes simultaneous microvascular clotting and bleeding caused by depletion of clotting factors and platelets, combined with excessive fibrinolysis. Electrolyte imbalances are common and result from hormonal and metabolic changes as well as fluid shifts. These changes exacerbate mental status changes, neuromuscular dysfunction, and dysrhythmias. Metabolic acidosis results from impaired tissue perfusion, as well as hypoxia, and a shift to anaerobic metabolism with a resultant increase in lactate levels. Progressive renal dysfunction also contributes to this metabolic acidosis because, of course, we're not absorbing that sodium bicarb the way we should because our kidneys are failing. So Kate is admitted to the ICU with a diagnosis of rule out of sepsis. Her urine output is amber and only 15 mils in 2 hours, which is not very good because an average is about 30 mils an hour. Chest x-ray shows bilateral infiltrates as well as white blood cell count and lactic acid levels that are elevated. So what kind of appropriate nursing diagnosis and goals for KR would you do? What are the assessment priorities for her? have you think about that. So MODS mortality rate are about 70 to 80% when 3 or more organ systems fail. Survival improves with early goal-directed therapy. The most common cause of death continues to be sepsis. Survival improves with early goal-directed therapy. Therefore, the most important goal is to prevent that progression of SIRS to MODS. Early aggressive surgery is recommended to remove necrotic tissue if that may be the issue, such as early debridement of burn tissue, that can provide a culture medium for microorganisms. Of course, prevention and treatment of infection would be, especially the source that's causing the infection, and early antibiotics would be helpful. And certainly in these hypermetabolic states, some nutritional and metabolic support, as well as appropriate support of individuals failing organs. So Kate has a fully inserted as well as a central venous catheter. Her doctor talks with her mother about the possibility of mechanical ventilation, and Kate's mother asks why she is so sick and what can be done for her. So, what interventions could they anticipate? Well, for Kate, she might get some antibiotic therapy. If she's under mechanical ventilation, she could be also getting sedation. And because of her hypermetabolic state, she could be also consulting about her nutrition because she's going to need that energy to get better. How might you respond to her mother's questions and concerns? I think something to consider is if you don't have all the answers, just be like, we are actually trying to look for those answers and we will tell you as soon as we know. Of course, the doctor will be in and talk to you about that and answer any further questions you might have. It could go like that for an example or go in other ways, but we want to make sure we validate her question and try to find those answers for her. If there's no answers because the doctors aren't sure, we just need to be honest about that. So it's all about prevention and treatment of the infection. So again, that means maybe removing necrotic tissue that can provide a culture medium for microorganisms. That's strict asepsis that can decrease infections related to things like intra-arterial lines, maybe endotracheal tubes, urinary catheters, IV lines, and other invasive devices or procedures. And then, of course, send appropriate cultures and start broad-spectrum antibiotic therapy as ordered based off those results. Now, remember, those don't really come back for about 48 to 72 hours. But adjunct therapy should be based on the culture results if needed. So aggressive pulmonary management, including early mobilization, can reduce the risk of infections. These patients have a greater oxygen need and decreased oxygen supply to the tissues. So oxygen delivery may be optimized by using individuals' tidal volumes with positive end expiratory pressure, or PEEP, increasing preload with fluids or myocardial contractility to enhance cardiac output, or reducing afterload to increase cardiac output. Certainly, though, with oxygen demand, we want to maybe have them rest as much as possible and cluster care. And of course, if there's any need for pain medications, we would provide analgesia or even sedation for mechanical ventilation, especially if someone's fighting the vent and causing anxiety and, of course, problems. So a lot of times propofol might be used or Precedex, depending on the facility. Protein calorie malnutrition is one of the primary signs of hypermetabolism and MODS. Because of their relatively short half-life, monitor plasma transferrin and prealbumin levels to assess hepatic protein synthesis. The goal of nutritional support is to preserve organ function. Providing early and optimal nutrition decreases morbidity and mortality rates in patients with SIRS and MODS. The enteral route is preferred. If it cannot be used, parenteral nutrition should be considered. Provide glycemic control with a goal of 140 to 180 with insulin infusions in these patients. And remember that the total energy expenditure is often increased in these hypermetabolic states to 1.5 to 2 times. So options would be things like tube feeding or even TPN if tube feeding is contraindicated. So the nurse notes that Kate has developed petechia and jaundice. What do they indicate? Well, jaundice indicates an increase in bilirubin level that is related to impaired liver function. So I would suspect her liver is having some problems. The petechia could indicate disseminated intravascular clotting, or DIC. What are some treatments that you would anticipate being done for her? Well, priority is aggressive treatment of the infection that's causing all this. Maybe maintenance of oxygenation, which is maybe intubation and the use of mechanical ventilator, and assessments of all body systems and support as needed. So how do we support these failing organs? Well, continuous renal replacement therapy is better tolerated than hemodialysis. And remember, that's used only really in the ICU, but it's for hemodynamically unstable patients, which would be shock patients, especially in patients with hemodynamic instability. And this is kind of like a continuous renal replacement therapy is kind of a mimic of your own body's way of filtering out the waste products and balancing the fluids in your body. It is important to maintain communication between the healthcare team and, in most cases, the patient's caregiver regarding realistic goals and likely outcomes for these patients with MODS. Withdrawal of life support and starting end-of-life care may be the best option for the patient, depending on the kind of prognosis in a sense. But usually they'll have a meeting with the family or whoever is the POA, which is the power of attorney, and they'll kind of determine what kind of the prognosis as well as probability and quality of life are, and have those discussions to see if palliative care or even hospice care needs to be consulted. So let's test ourselves again. A patient with a history of alcoholism is admitted to the ICU with a hemorrhage from esophageal varices. Admission vital signs are, of course, BP 84/58, which is low, a heart rate elevated at 105, and respirations elevated at 32 a minute. The nurse recognizes the onset of SIRS upon finding A, pulmonary edema, B, cardiac dysrhythmias, C, absent bowel sounds, or D, decreasing blood pressure. So we're talking about SIRS. So the answer is actually A. The respiratory system is often the first system to show signs of dysfunction, as I mentioned in this lecture. In SIRS, increasing in capillary permeability facilitates movement of fluid from the pulmonary vasculature into pulmonary interstitial spaces. The fluid then moves to the alveoli, causing alveolar edema and pulmonary edema. So a patient admitted to the hospital from a long-term care facility appears to be in the late stage of shock with SIRS. Which order implemented by the nurse has the highest priority? A, insert an indwelling urinary catheter. B, insert 2 large bore intravenous catheters. C, administer 0.9% normal saline at 100 mL an hour. Or D, administer 100% oxygen by non-rebreather mask. Well, these all look really good. So how do I know what the highest priority is? Well, if I think back on my ABCs, I might have my answer. So if you guessed D, you were correct. A patient in the irreversible stage of shock or late stage will demonstrate profound hypotension and hypoxemia. If the condition progresses to systemic inflammatory response syndrome, the patient may experience profound hypoxemia. Oxygenation is a priority and should be initiated first with 100% oxygen delivery methods such as a non-rebreather. And this concludes our lecture.